Assalamu alaikum. In the next 15 minutes, I will review why should we advise all pregnant women with hyperglycemia not to fast in the month of Ramadan. I will be discussing glycemic targets and outcomes in hyperglycemia in pregnancy. I will talk about the impact of Ramadan fasting on healthy pregnant women and also on women with gestational diabetes and hyperglycemia. I will review the impact of water restriction on pregnancy, and I will touch base with the 2021 DAR Alliance practical guidelines. Now, as you know, most of the hyperglycemia cases in pregnancy are actually related to gestational diabetes, and the rest are related to type 2 and few cases of type 1 diabetes. The incidence or the prevalence of gestational diabetes in our community is about 40%, according to studies from our hospital, where it is as high as 15% in the Western countries. The risk of adverse outcomes continually increase with the increased blood glucose, starting from week probably 20 and more, and now recent reports would say that will increase from week 12 actually. And there is no threshold for a certain risk. So a different patient might have different risk at the same glucose levels. Now, the complications of hyperglycemia in pregnancy is well known to this audience. It affects the mother and also the fetus. Now, the ADA recommendations for pregnant women with hyperglycemia that they should take regular meals throughout the day. They should have strict glycemic control. We are talking about less than 95 in the fasting state, less than 140 after 1 hour of meals, and 2 hours after meals should be less than 120. And for those patients who already have established diabetes type 1 or type 2, the A1C should be less than 6. Now, medical treatment is indicated whenever patients with gestational diabetes are not achieving targets using the diet therapy. And now it's clear that insulin is the preferred treatment for gestational diabetes and type 2 diabetes. Now, also the ADA set some specific goals for sensor ranges in pregnancy. And you could see here for time and range that the normal range is between 63 to 140, and it should be more than 70%. Time above range, and above range means above 140, should be less than 25%. And time below range, level 1, less than 63 should be less than 4%, but less than 54, level 2, should be less than 1%. So what's the impact of Ramadan fasting in healthy pregnant women who have no diabetes, no gestational diabetes, nothing? And in this study from Al Ain City, it compared women who fasted the month of Ramadan with those who did not fast the month of Ramadan, or it was after Ramadan actually. These patients did not have any diabetes or gestational diabetes, and clearly there was no difference in the fasting blood glucose between the two groups. However, the 1 hour post break in the fast versus the 1 hour after meal in the second group showed a higher blood glucose in the group who fasted the month of Ramadan. So 1 hour postprandial is higher in the group who fasted Ramadan. And in this group, also women who fasted the month of Ramadan had increased incidence of gestational diabetes. All of these outcomes were significant, had increased induction of labor, had higher C-section rate in the fasted group always, and they had more admissions for the babies to the neonatal ICU. All of these were significant. Again, remember, these are not patients who did not have any gestational or hyperglycemia in pregnancy. In this study also, it was clear that women who fasted during the month of Ramadan had a decreased number of large acceleration when when measured by the fetal heart rate in pregnant women, and that indicates the movement of the baby. So again, fasting affected that parameter. So let's now move to hyperglycemia in pregnancy and Ramadan fasting. Now, these are the facts. The impact of Ramadan fasting on glycemic levels in hyperglycemic pregnancies is not well known. The impact of Ramadan fasting on maternal and neonatal outcomes in diabetic pregnancies is not known also. And finally, the most efficient way to monitor blood glucose during fasting is not even established. Now, there are so many reports on complications that happens during Ramadan fasting, and I put some of them here mentioned earlier in the complications in pregnancies with no fasting, but these are exaggerated during Ramadan fasting. We're talking about hypoglycemia, hyperglycemia, DKA, dehydration, preeclampsia, FGR, preterm birth, and so on. So all of these are evidence about the outcomes during Ramadan fasting. Now, in this study, we studied the glucose changes in pregnant women with gestational diabetes during Ramadan fasting. We divided the patients to pre-Ramadan group that was obviously on diet only. We had a Ramadan group that was on diet, and also we had a Ramadan group who was on diet plus metformin. Small study, however, very informative. You could see that the patients during Ramadan fasting have increased incidence of hypoglycemia, especially in the group who was on metformin. Even the group on diet only had increased incidence of hypoglycemia compared to pre-Ramadan diet-only group. Now, also, the severity and frequency of hypoglycemia, you could see here that the prevalence of hypoglycemia was more often in the diet plus metformin group, but the severe hypoglycemia was more common in the diet-only group. You could see here the level of the hypoglycemia, and less than 50 was in 23% of the hypoglycemic cases in the GDM fasting on diet only, compared to lower but higher than the diet before Ramadan risk of hypoglycemia in the metformin group. So patients on diet only, patients on metformin and diet have increased incidence of hypoglycemia during Ramadan fasting compared to the group that did not fast. The study conclusions, CGM reveals that Ramadan fasting increased the risk of moderate and severe hypoglycemia in women with gestational diabetes treated with diet alone or with diet plus metformin. Now, in this study, we compared the glycemic profiles provided by CGM. We compared that with the SMBG in gestational diabetes patients. And again, a small study, diet plus metformin patients. And in this study, we showed clearly, it was shown clearly that the CGM revealed more hypoglycemia compared to the blood glucose meters. That was really significant. The mean blood glucose was better in the CGM, and the incidence of hyperglycemia on the blood glucose meter was significantly higher in the blood glucose meter. So you're talking about almost triple the rate of hyperglycemia. Now, when we compared the frequency and severity of hypoglycemia, you could see that all cases of hypoglycemia on glucose meters were mild, level 1, less than 70, but more than 50. And on the CGM, we have more incidence of hypoglycemia between 50 and 69, and less than 50 severe hypoglycemia, and there was none on the glucose meters. So you could see a big difference in the readings here. Now, when we looked at the hyperglycemia, again, that was more prevalent on the glucose meters, and you could see significantly higher blood glucose time in range, and even over than 180, and all of them were significant also. So here is the reason why we have this discrepancy. It was clear to us that patients who were using the glucose meters were not checking, they were only checking between 7 p.m. and 4 a.m. in green. So they were checking at the wrong time, actually. That's why they caught more hyperglycemia, where they missed to check between 4 p.m. and 7 p.m. It was only 9% of the readings, and that's where most of the hypoglycemia, as we know, happens, and these were missed by glucose meters. Now, the study conclusions were CGMA facilitate the detection of hyperglycemia by providing complete picture, and relying on glucose meters in the management of GDM patients might be misleading. This is a comparison between non-Ramadan and Ramadan CGM SMBG studies. And clearly in our case, in Ramadan cases, there is acceptable frequency of blood glucose checking. However, the timing was inappropriate, and that's why Ramadan fasting study overestimated the hyperglycemia, and underestimated the hypoglycemia. The impact of water restriction in pregnancy is not well studied, but clearly it causes some abnormalities, including neural tubal defects and deformation of hands and feet, and premature labor and birth. Now, according to the previous guidelines, hyperglycemia in pregnancy is classified as a high risk for patients, and the 2021 guidelines say clearly that risk of morbidity and mortality to the fetus and mother is not well established. So all pregnant women should be advised not to fast. Now, all pregnant women, I think all pregnant women or pregnant women with diabetes or gestational diabetes or lactating women, all of them are actually not fit to fast, and they should be advised as such. Yes, we know that many of them will fast against medical advice. In our community, we reported that 59% of pregnant who are advised not to fast do fast, and these patients, we reported that they have increased risk of hypoglycemia and hospital admissions. So what happens if they insist on fasting? Fine. If they insist on fasting, they have to know that they're at a very high risk level, and they should be informed and aware of all potential risks. And then clearly that these patients should be referred to high risk clinics where you have a multidisciplinary team approach. My take-home messages: the impact of Ramadan fasting on patients with hyperglycemia in pregnancy is not well known. The impact of water restriction during Ramadan fasting on pregnancy hemodynamics is not well known as well. The accuracy of CGM during Ramadan fasting is not even well established, and that's why exemption from fasting during pregnancy is the safest approach. And that was the last slide. Thank you very much.